Hi everyone, I am Dr. Stanley Lau. I'm here with Dr. Balakian. And Dr. Balakian is the ICU director at Garfield Medical Center. He's a specialist in critical care and also pulmonology. And today we have the privilege to have him to talk about his approach on COVID-19 patients who have difficulties in breathing. Dr. Balakian, so could you tell me that the things that you have done differently in this hospital?
So one of the big things that we do differently here in this hospital compared to other places locally is we make sure to have the 4 Ps for patients who have ARDS, acute respiratory distress syndrome. Number 1 is the peak pressures. We want the pressures inside the lungs to be low when they're on the breathing machines. Number 2, we want their PEEP to be higher, and that's to help recruit as much healthy lung as possible. The 3rd P is we paralyze patients to make sure that they are calm and resting as their lungs get better. And also number 4, we do proning, which is actually changing the positioning of the patients while they're sick to help the lungs heal more quickly.
Now, what is ARDS, by the way?
So ARDS is acute respiratory distress syndrome. So it's an illness of the lungs. It's a lot of inflammation in the lungs that is caused by a variety of factors, usually a pneumonia, but sometimes other things, for example, sepsis, infections other parts of the body, or even inhaling, for example, vaping-related lung illness can cause ARDS. It's not uniform. Some areas of the lungs are sick, other areas of the lungs are healthy. And when you actually turn them over, the healthier parts of the lung are actually up in the front, so when you turn them over down on their stomach, the parts of the lung in the back that were full of mucus and nasty stuff can actually drain it and get better. And this is not only for people on the machines, as you said, people who are awake, if they're requiring oxygen via a nasal prong or a face mask. If they're feeling short of breath on their back, we can actually help them turn on their stomach and they actually breathe better and require less oxygen. And actually, if you prone people who are not intubated and just need the nasal prongs or the face mask, in those patients, you actually avoid having to put them on life support and having to put the breathing tube down their throat because you prone them early.
Could you explain to me a little bit more in a more simplistic term that why proning helps?
Sure. First studies on proning came out of France in 2013. And then back then they saw that if you actually lay patients on their stomach for 16 hours and then flip them back for 4 hours, that actually helps the sick lungs get better quickly than if you left them on their back the entire time. You can imagine that if somebody is on their back, then I have this entirely large area of my back where that entire level of lung in the back is just closed down. And that is lung that is not being used and not exchanging oxygen. So when we lie on our backs for very long, those areas of our lungs close up and they do not help us take oxygen into the body. So by turning the person over, what you do is you pop open those areas because of gravity, and then you would expect the front parts right over here to start closing down, and indeed they do, but when it's time for that to start happening, you put the person back. So this constant back and forth keeps as much of the lung open as possible so you exchange oxygen and get it to your tissues. So typically we would do proning for patients who are so sick that they had to be sedated and also paralyzed. So that essentially they were not helping out. They were just a ton of bricks. So you would actually have to get 2 people on either side of the patient to help roll them. And an additional 5th person at the head of the bed making sure that the tubes did not come out while you were turning the patient. So because this requires 5 people to turn the patient over and then turn the patient back again 16 hours later, because of that increased manpower, a lot of places are hesitant to do it. Despite that, half of the patients in the group that were proned survived compared to the other patients in the non-prone group. So 40% of patients in the standard care group died, whereas only about 15 or 20% of the patients in the prone group died. So even though there is a risk of things dislodging, it is worth it because you decrease your mortality by half.
You mentioned about 16 hours on the front. So would you imagine any potential injury to the patient when you're doing this?
Yes. So we as human beings were meant to be standing for the majority of the day, definitely not on our backs, and most definitely not on our fronts. So we do see patients occasionally developing skin ulcerations, essentially like bed sores, but on their very fragile skin, forehead, cheeks. And for that reason, we make sure that we have pillows on their chest and on their pelvis, as well as on their face. And also every 2 hours, the nurses will turn the patient's face so they do not get bed sores on their very fragile facial skin.
I heard the lady, there's some COVID-19 patients that that under your care, and you have some experiences in using this prone technique. Could you tell me something more about it?
Yes. So currently we have a total of 4 patients that we've treated in the last week with COVID-19 in our intensive care unit. 3 of them required the machines and also proning by us because they were unconscious and paralyzed. One of them, a 72-year-old gentleman with heart failure, we were able to take the tube out. He has recovered. The other 2, one is 77 years old. She is expected to recover. We're probably going to take the tube out in the next day or 2. And the third person, she is 56 years old. She also is recovering. We expect her to be off the machines within that same 2 or 3 day period. The last person is actually on a face mask, and she is cooperating with people turning her over. So it only takes about 1 or 2 people to help her turn over on her front, and then when it's time to eat, she goes back on her back and eats, and then goes back on her stomach. The earlier we can start these maneuvers, giving small volumes so that we're not overinflating patients unnecessarily and also paralyzing them and proning them, the sooner we do that, the sooner we actually let their bodies rest and also minimize the inadvertent harm that we are causing to their lungs with these very large breaths that we would normally traditionally give. If we do get it where there's a surge, we will make sure that we prioritize and get people the things that they need as early as possible, because we should not deny them helpful standard of care just because we have not operationally got our stuff under control.
And I think that we are fortunate that you initiate this technique in Garfield Medical Center. Thank you very much for your time, Dr. Balakin.
Of course, thank you.